Hi, my name is Congenital and you're watching the video Fourth Cranial Nerve Palsy Management. In this video, we'll be discussing the non-surgical and surgical intervention options for patients who've been diagnosed with the fourth nerve palsy. We'll begin with non-surgical management, and as we've discussed in the video on the principles of conservative management of patients with neurogenic palsies, the options, or the main options we have in terms of managing a patient, is using prisms or occlusion, or assisting the patient with an abnormal head posture. So clearly these are techniques to deal with the patient's diplopia, and we can look at a variety of options from sector occlusion to sector prisms. And a reminder that where you do select prisms or frenels, you should always try to correct the vertical deviation first. Now, the fourth nerve palsy will have a vertical component, so you want to address that first when you're considering frenel prisms, and then deal with the horizontal component if the vertical is not sufficient. Now, patients who are diagnosed with a recently acquired fourth nerve palsy are going to have an extensive workup to find the etiology of the fourth nerve palsy. Now, we obviously do the same with congenital or long-standing, but with the recently acquired fourth nerve palsy, it is possible that the cause could be sinister. The patient might need to have an MRI, a CT scan. They could have a space-occupying lesion that needs to be diagnosed and addressed. So a thorough history will be taken in these patients, and further clinical investigations may be required to get to the bottom of what caused the fourth nerve palsy. As I've indicated in previous videos, remember that you have to wait for a minimum of 6 months before any surgical intervention is undertaken. So during this period, or whilst you're waiting for the deviation to stabilise, you need to manage the patient's diplopia, and you do so with the possibilities we just discussed a moment ago: frenels, occlusion, or abnormal head posture if possible. Where you have a child with a fourth nerve palsy, the other considerations you will need to make are the refractive error. You may need to correct refractive error to assist or prevent any amblyopia occurring, if there's any anisometropia, for instance. And also, if there's any suppression and amblyopia is developing, then you will need to also prescribe treatment for amblyopia. And generally this will be occlusion, but you're obviously open to any options there. You could do optical penalisation, atropine penalisation, whatever you've learnt in the past in relation to amblyopia management. Specifically relating to a decompensating fourth nerve palsy, again, these are patients who have had long-standing fourth nerve palsies. They've been controlling the deviation and have now lost control of the deviation. So when they present to you, this will need a bit of further investigation too, to see if you can find out why the deviation has commenced decompensating. It could be that there's a change in refractive error, for instance, or there could be a change in visual acuity between the two eyes that's precipitating them losing control of the deviation. So you need to explore other reasons why the patient might be decompensating, and then address that as required. In the first instance, we're often trying to manage these decompensating patients through conservative means, because these are patients who were once happy, were controlling the deviation, and they've presented to you now because they've lost control. If it's a small deviation, you're probably going to be able to assist the patient. If it's relatively large, it may require surgical intervention, depending on whether you can assist them in gaining control of the deviation, or whether prisms, for instance, assist them in having comfortable BSV. Let's now move on to surgical intervention for fourth nerve palsy. Quite a number of patients will progress to surgical intervention for this condition, and generally we'll do so, one, when the deviation is stable. Secondly, if conservative treatment isn't possible and does not provide a patient with comfortable BSV, particularly if you've got large angle deviations, this can be problematic. If the patient is concerned regarding the ecosmesis in relation to either the deviation or the abnormal head posture, this is a reason for surgical intervention, as well as if the patient cannot regain control of the decompensated deviation. Just a note about the abnormal head posture. If a patient is now an adult and they've had this abnormal head posture since an infant, be aware that it can be extremely difficult for patients to let go of that abnormal head posture. So this will need to be taken into consideration in surgical planning, and often undercorrections are made where there's a long-standing abnormal head posture. The other consideration is if you have a congenital long-standing palsy, you need to carefully consider whether you are going to achieve a functional outcome or a cosmetic outcome. So these patients will need to have their binocular functions assessed and to look for suppression scotomas, map those suppression scotomas if present, and look for post-op diplopia testing. The reason why I specifically indicate this under congenital long-standing is that with a recently acquired palsy, assuming that the patient is past the critical period, most of these patients will have binocular functions prior to whatever led them to have the fourth nerve palsy. So generally these patients will be having a functional outcome. However, you can't assume that. You'll obviously need to test for the patient's capacity to have BSV. But it is very likely that if they've had no other ocular problems in the past, that they'll have BSV and can regain BSV post-operatively. Just one more point about binocular functions. If you find that a patient has extended fusion ranges, or an extended fusion range, and we particularly find these in the vertical direction, this needs to be taken into consideration when planning for surgery. Often, we'll need to consider an undercorrection where there's large fusional divergences. The other, again, I just mentioned in relation to the abnormal head posture, a long-standing abnormal head posture should be considered when planning for surgery and having a think about undercorrecting the patient in these particular instances. Now, in relation to surgical intervention for fourth nerve palsies, we're going to be targeting the muscles that are involved in the muscle sequelae. So we have the palsied right superior oblique. We usually have an overaction of the right inferior oblique. We have the overaction of the left inferior rectus, and then we have the secondary inhibition or underaction of the left superior rectus. So we have the option of strengthening the underacting muscles. Here we have the superior oblique and the superior rectus, or weakening the overacting muscles, the right inferior oblique and the left inferior rectus. In general, the surgical intervention for the fourth nerve palsy tends to target either the inferior oblique, the superior oblique, or the inferior rectus. Now, earlier in one of the previous videos, we've discussed the fact that in long-standing fourth nerve palsies, we can have contracture of the ipsilateral superior rectus. So this muscle as well is considered in surgical intervention where relevant, and we'll see as we go through the NAPS classes again as to which instances we would target the superior rectus. Let's start off with the strengthening procedures, and specifically with the strengthening of the superior oblique. The preferred procedure for this is a superior oblique tuck. Generally, a superior oblique is not resected because of the anatomy of the muscle. Now, with a tuck, the maximum tuck that should be done is about 10 to 12 millimetres. And there is an issue if a patient has a superior oblique tuck and the strengthening procedure has gone too far. If this happens, what will happen is that there will be a restriction of elevation in adduction. Just like we see in class 7, the canine tooth syndrome, where the superior oblique damage causes the eye not to be able to elevate in adduction. This will happen with a superior oblique tuck that's gone too far. The eye will not be able to elevate in adduction, in which case you will have created a Brown syndrome, and this is considered an iatrogenic Brown syndrome. This particular procedure is very, very useful in patients with a congenital fourth nerve palsy who have a floppy tendon. So this is the preferred procedure in that instance. And then where you have an acquired fourth nerve palsy, you need to be more conservative, and generally surgeons will do much less than 10 to 12 millimetres so that they can avoid a Brown syndrome. The other consideration is that the superior oblique tuck is reversible. So should they over tuck the superior oblique and they create a Brown syndrome, then there is the potential of going back in should the limitation of elevation and abduction be significant. Let's have a look at what a tuck looks like. This is a superior oblique palsy where we have the patient, and they've got an excyclotropia in this particular instance. Here is the superior oblique here. And what we can see is that what will happen is that the superior oblique will be targeted and essentially tucked. Moving on now to weakening procedures. So as I mentioned earlier, you'll be targeting the muscles that are overacting to weaken them. So that could be the ipsilateral inferior oblique. We can either recess the inferior oblique or a myectomy can be performed on this particular muscle. The other procedure that can be done is targeting the inferior rectus, so the contralateral synergist. In this instance, it's a rectus muscle. Recessions are often performed on rectus muscles. Our other option is to weaken the ipsilateral superior rectus. This is for the patients with a long-standing fourth who had a contracted muscle. Again, because this is a superior rectus, we can actually look at recessing that. And one more procedure that we haven't learnt about as yet, the Harada-Ito. The Harada-Ito is a procedure specifically for excyclotropia. So it is a procedure that targets patients who have a primary concern of torsion. So often patients like a bilateral fourth nerve palsies, which may have quite significant torsion, may require Harada-Ito. This procedure takes half of the superior tendon and displaces it anteriorly and laterally. Let's have a look at this. In this particular example, this is the superior oblique we're going to be looking at that will have the Harada-Ito procedure performed. And we can see that this is the fanning of the superior oblique, and half of it will be moved anteriorly and laterally. This will have a significant impact on torsion. There is also a video available on LMS for you to look at a Harada-Ito procedure. Now let's go through NAPS classifications and determine what is the preferred surgery for each class. Remember, in the video on NAPS classifications, I mentioned that one of the purposes of classifying your patient who has a superior oblique palsy is to inform the surgery. So it's really important to carefully measure the deviation in 9 positions of gaze where you do have a fourth nerve palsy, so that you can identify what class of superior oblique the patient has and therefore determine the best possible surgery for that patient. Let's commence with class 1. You remember that class 1 is where the deviation is greatest in the field of action of the ipsilateral antagonist, so where the inferior oblique has its action. Again, we'll be working with a right superior oblique as an example. So in this particular instance, we will want to target the right inferior oblique and weaken this particular muscle. A recession could be performed on this muscle or a myectomy. Class 2, now we have the deviation greatest in the direction of action of the palsied muscle, so in the direction of the superior oblique. So we want to target the superior oblique. To strengthen it, as I mentioned earlier, we would be looking at tucking the superior oblique. However, we also need to consider that by tucking the superior oblique, we run the risk of creating an iatrogenic Brown syndrome. So should this be a concern, you can move over to the left inferior rectus and weaken this particular muscle, which is generally overacting as the contralateral synergist. So by weakening this muscle, what we'll do is we'll match the defect on the left side to that of the right eye, and through that we'll actually have BSV in dextrodepression. Class 3, now we have the hyperdeviation being greatest in and equal in the contralateral positions of gaze just here. So we have the issue in the position of the ipsilateral antagonist and of the paretic superior oblique. So in the first instance, the right inferior oblique is a good choice in terms of weakening, and then we can add either a tuck of the superior oblique or a recession of the left inferior rectus. Generally speaking, an inferior oblique recession or myectomy on its own may be enough if the deviation is relatively small. Depending on which textbooks you read, the superior oblique tuck or the contralateral synergist recession should occur if you have a deviation in primary position that's about 25 diopters. Some textbooks will go as low as indicating greater than 10 or 15. So this value is a little bit variable, but generally if you've got a significant deviation in primary position, you'll want to add one of the depressors to the elevator being weakened. Class 4, now we have a patient with a hyperdeviation which is greatest along the contralateral gaze positions and along all of down gaze. Now remember, the reason why you have the deviation along the entire down gaze, or the reason why it's greatest along the entire down gaze, is because of a tight superior rectus. So we need to target that superior rectus and weaken it in relation to the fact that it's a rectus muscle. A recession procedure would be sufficient for this. With regards to the deviation being greatest also along the contralateral gaze position, we would consider what we did with the class 3. So we can go after the inferior oblique here to target dextral elevation, or we can go after the superior oblique or the left inferior rectus if we need to. Class 5, we have the hyperdeviation greatest along all of down gaze positions. So in this instance, we can again target the right superior rectus as the contracted muscle and weaken it. Or the other option is to target the superior oblique tucker or recess the left inferior rectus, dependent on what we find on deviation, the size of deviation, and what's the preferred option. Class 6, the bilateral superior oblique. There isn't a lot of consensus in relation to the bilateral superior oblique as to what should be performed in this instance. Often bilateral inferior oblique recessions will be performed, and should your patient have significant torsion that is impeding on their function, then the preferred procedure is certainly the Harada-Ito, and this can be done bilaterally. So, as an example, you could have bilateral inferior oblique recessions and bilateral Harada-Ito procedures performed where there is significant torsion in particular. However, you could also classify the right superior oblique independent of the left superior oblique and classify it as a type 1, type 2, etc. In which case, you could alter this surgery to reflect how you would perform surgery for those types of superior oblique palsies. The class 7 K9-2 syndrome, this is a difficult one to manage, and surgeons prefer to leave alone if they can. If the primary position deviation is negligible and the patient is straight, for instance, then certainly the surgeons will not want to operate on this sort of patient. There are options such as operating on the yoke inferior rectus and weakening this. However, surgeons will make a decision case by case. They'll often explore the trochlea as well and see how much scarring may be in this particular region around the superior oblique and around the trochlea from the trauma. So the surgical decision may alter dependent on the surgeon and depending on the case. But the preference is to avoid surgery if you can. And here is a flowchart of what we've just discussed, the preferred surgical intervention for the various classifications of the superior oblique palsy. And here I've provided you with a flowchart for the surgical intervention for a congenital fourth nerve palsy. Now, I haven't mentioned this much in the video. However, I did indicate that where you have a floppy tendon, so that first category here, the class 1, we would do a superior oblique tuck. Now, for the purposes of this subject, I want you to know this, because 90% of your patients will have a floppy tendon if they're congenital and will have the superior oblique tuck. This is the preferred procedure above all other procedures that we've learned about in this video. However, please also be aware that should the tendon, the superior oblique tendon, be misdirected or absent, there are other options for the surgeon. So I've listed these here where you'll see that a misdirected tendon, if it's nasally, they'll transpose it, but if the superior oblique is inserted in the tenons, then the surgeons will actually go for other extraocular muscles. And again, also, if the tendon is absent, they don't have an option to work on the superior oblique, so they will go for other extraocular muscles. Okay, so in summary, you always need to wait for a recently acquired neurogenic palsy for at least 6 months to ensure that the patient is either stable before any further surgical intervention is considered, or to see whether the patient spontaneously recovers. So during this period, manage the patient conservatively, manage their diplopia. Also ensure that where there's a recently acquired neurogenic palsy, that you have a look at referring on to other clinicians where appropriate to determine the cause of the fourth nerve palsy. You will also need to do some exploring in terms of your congenital patients, obviously, and your long-standing patients in terms of what may have been the cause in the past for the fourth nerve palsy, and your decompensating fourth nerve palsies will also require you to explore if there's any particular reason why the patient has begun to lose control of what they used to control, a hyperdeviation. In relation to surgical intervention, remember to consider binocular functions where you have a patient with a congenital or long-standing fourth nerve palsy, or where a patient has particularly extended fusional divergences or an abnormal head posture that they've had for a very, very long time. Consider your planning in terms of surgical intervention and know that you may need to think about an undercorrection in these particular instances. Consider NAPS classifications and torsion when developing your surgical management plan. Each of NAPS classes has a very specific extraocular muscle that it targets because the deviation is greatest in different positions. And finally, consider if your patient has a congenital fourth nerve palsy. If you're operating on a congenital fourth nerve palsy, it's likely the patient has a floppy tendon, so the superior oblique tuck is preferred in this particular instance. And also, if you don't have a floppy tendon and you do perform a superior oblique tuck on your patients, do know that there is the risk of a Brown syndrome being iatrogenically created. So watch out for that and ensure that where a tuck is done, it's not maximal in patients with no floppy tendon. Okay, that brings us to the conclusion of this video. Thank you for watching.